Hello, everyone. Hello, hello. How's everyone doing? Welcome to VMR today. Super excited to discuss again. Ravi, how you doing?
I'm absolutely fantastic, doing well. Just got off interview session here at Sinai is in full swing, day number two, and getting to see so many fantastic applicants. I'm just amazed. I was just telling Mark about some of the stories that I've heard. It's just incredible, but just absolutely glad now to switch my brain from interviewing to clinical problem solving. So yeah, I'm doing wonderful. Thank you.
Awesome. And Patricia and Masa, would you guys like to just say a word? Just and thank you so much for scribing and doing teaching points.
Hey everyone, I'm Masa. I'm a medical graduate from the United Arab Emirates, and I'll be scribing today.
Hi everyone, I'm Patricia. I am a IMG from Cameroon and I will be doing teaching points today. I'm really excited about the discussion.
And then the famous Vinny, very scared for another Vinny case. Would you mind saying a word?
So, hey everybody, I'm Vini. I'm a medical student from Brazil, and I'm very excited for today's case. And yeah, you're ready.
Awesome. Yeah, whenever you're ready, Vinny, we are ready for that first aliquot.
Okay, so I'll just wait for the whiteboard. And what for the first aliquot, I'll start with a 42-year-old man that presents with 2 weeks of history of progressive fatigue and also progressive jaundice. I'll stop here.
Awesome. Wow. Fire from the beginning. All right. So we have fatigue and jaundice. And honestly, I'll just focus on jaundice here. Fatigue might give us a sense of how severe this condition is, but I think there's going to be a lot more cognitive energy we should spend on jaundice. So a middle-aged man with jaundice. So I think I've said this, and I think we all talk about this a lot, is that anytime you have a clinical symptom or a lab abnormality or a vital sign abnormality, always root yourself in the no misdiagnoses first. What do I have to rule out right away in the emergency room when I'm seeing that patient, right? What's going to be most life-threatening, right? So right away when someone's jaundice, I'm gonna want to evaluate for acute liver failure, right? I'm gonna want to get a good sense of the patient's mental status. I'm gonna want those liver function tests to see if the patient has a severe hepatocellular liver injury, and I'm gonna want some coagulation studies to see if the patient has coagulopathy, right? Because you need alter mental status, severe liver injury, and then coagulopathy to diagnose acute liver failure. So that's something I'm going to want right off the bat, right? Um, and then another thing to think about is, infectious causes of jaundice, right? And really what I'm talking about here is cholangitis, right? Cholangitis can be pretty deadly and can progress pretty rapidly, just like any cause of, GNR bacteremia or GNR infection, right? And then the last thing I'll think about is just hemolysis. And the and the reason why maybe, maybe we'll get a signature of hemolysis here is maybe the fatigue is a sign of anemia, right? Because fatigue is non-specific, but it could be a sign of anemia and hemolytic anemia resulting in jaundice. Um, I think other things like in the HPI that could help me move towards either this being an unconjugated hyperbilirubinemia leading to jaundice, or a conjugated hyperbilirubinemia or mix leading to jaundice is really if the patient's having any abdominal symptoms, right? If someone has a hemolytic anemia, they might have signs of anemia, right? Fatigue, tiredness, lightheadedness. But if someone has a more mixed or conjugate hyperbilirubinemia, that is from some sort of, hepatobiliary process. A lot of times they have, abdominal pain. They may have acolic stools, dark urine. So there's some things I would focus on in the HPI. But I'm definitely going to be assessing the mental status. Definitely going to be wondering any systemic signs or symptoms of infection and cholangitis. But that's kind of where I'd start here. The first labs I'm really interested is in those liver function tests, the CBC, and the coagulation studies. How about you, Robbie?
Oh, absolutely wonderful initial aliquot, Vinny there, and fantastic sort of walk through there, Mark. I think when you see jaundice right off the bat, first of all is trying to identify. One of my favorite sims is a patient with jaundice, and then what I do look for the person that's doing the simulation is can they identify the jaundice in this patient, and can they then identify and walk through in a pragmatic manner what could be causing it. So you're right, the fatigue is non-specific. It is associated with this, and I think there is inflammation that's surrounding this, and inflammation, systemic inflammation, can cause such a presentation. And sometimes it can be very discreet. So patients come and they don't even realize until, so first skeletal icterus, the bilirubin may be 2 to 4, above 4 to 6. You would say the bilirubin, you get skin jaundice. So sometimes it's not apparent until somebody tells the patient, hey, your eyes are looking yellow, or you're looking kind of yellowish with this hue. I also would kind of make a point with darker skin patients. It can be a little difficult until the levels are in such a severe range that you start to look jaundice. So I don't know about the skin color of the patient, but the presentation can be missed in a darker colored patient as well. I think Mark went through the anatomical causes very well, and I think with a exclamation point anemia, right? Hemolysis could be a cause here. The other area or part of this landscape would be the inherited non-hemolytic hyperbilirubic state. So we talked about inflammation causing fatigue, but sometimes stress, inflammation could bring out a disorder of conjugation. So there are a number of different syndromes, although the caveat is the degree of jaundice isn't, or the elevation in bilirubin is usually not severe. So disorders of conjugation would be something like Gilbert syndrome, which is probably the most common type of this non-hemolytic hyperbilirubinemic syndrome. And then you have Crigler-Najjar syndrome, which is another one, and there's like 2 types, which is another disorder of conjugation. Then you might have a conjugation, or sorry, a disorder of reuptake, which is Roeder syndrome, and then a disorder of excretion into the bowel, which is Dubin-Johnson. So I doubt this is probably happening, or this is related to this case, but I just kind of like to explore. We at the beginning, we kind of want to do the academic exercise and cover the sort of different parts of the pathophysiology of, say, the condition that's being discussed here, which is jaundice. But it's something to keep in mind, because I did have a patient who was stressed by an infection, and because of that, they were jaundiced. And we got all excited about the jaundice, and we sort of didn't pay attention to that. The stressor and the inflammatory cause of this was the pneumonia in this patient. Back to you, Vinny. Anything else, Mark, before we move on back to the next aliquot?
No, the only thing I was thinking, just to push myself a little more, is like kind of thinking about, if a patient is getting admitted with jaundice and fatigue, that's a 42-year-old, what is really going to be the base rate and epidemiology of this? And I think really hepatobiliary disease, like, hemolysis is not all too common. On VMR, it's rather common, but in real life, it's not too common, outside of like, congenital hemolytic disorders like sickle cell disease, or kind of putting those aside, it's not too common. So I think base rate would say this patient probably has a hepatobiliary disease, whether, stone disease, extremely common. I admitted this exact same patient a couple weeks ago that had abdominal pain as well, and ended up having a biliary stricture, which could wind up being a rare disease, and I could follow up with you guys if it is. But yeah, that's the only thing I just wanted to add.
Oh, that you brought up a great point there. In this first aliquot, there are certain clues you would look for, right? So we don't have abdominal pain yet, and that would be a great indicator of right upper quadrant pathology, right? Painless, somebody had mentioned in the chat, a great thing. Is this painless jaundice, or is this painful jaundice? That is a great discriminator as well, what could be going on. And then fever. If there was fever, then you have to start worrying about, it could be hemolysis, it could be parasitic manifestation in the erythrocytes, or could it be a right upper quadrant infection / cholangitis or something like that? So these are semantic qualifiers, I think, if associated with this complaint, would help to clue us into where exactly the answer may lie with this case. And we could pretty much make progress at that moment. So we'll see in the next aliquot if we have a few more clues to help us pull back the sheets on what's going on with this case. Back to you, Vinny.
Perfect. For the second aliquot, the patient approximately 14 days ago And the patient developed significant progressive fatigue, unable to stand, and with no fever. And due to the severe symptoms, and the dialysis service team identified some test abnormalities. In the external hospital, severe anemia was detected, and the patient received 3 blood transfusions. And afterward, the patient reported progressive jaundice 2 days later, along with petechiae on the lower limbs, joint pain in the left knee, accompanied by inflammatory signs, and edema in the left lower limb. The patient denies nausea, vomiting, shortness of breath, or bleeding, and has no other complaints. So, for his past medical history, the patient has chronic kidney disease secondary to type 2 diabetes and pyelonephritis. And for 3 months, and the episode of pyelonephritis was 3 months ago, and he is on dialysis. It is insulin dependent diabetes. He also has hypertension, left ventricular hypertrophy, blindness, hypothyroidism, dyslipidemia, and obesity. About his family history, mother has a history of drug-induced cholangitis. About his medications, he's taking levothyroxine, hydralazine, carvedilol, amlodipine, folic acid, calcium carbonate, aspirin, insulin 40/040, erythropoietin, and 2 tablets once in a week, and also simvastatin. About his habits, he's non-smoker, no drug use, and no alcohol, no recent travels or allergies. So for the second aliquot, yes, he's in dialysis. He's a white person, and I don't remember. And yeah, about the fever, he denied fever though. So if you guys have any more questions, let me know. So that's all for the second aliquot.
Oh, there's quite a lot to unpack here. So what's interesting, the leg. The leg has several findings, and I think it definitely deserves our due attention. So on this leg, we're seeing um, petechiae in the lower limbs, there's pain in the lower limbs, and inflammatory signs and edema in the lower limbs. So I'm trying to make sense of that. So this has happened over 14 days. So you kind of have to wonder about it's not a sudden, not something that could be life-threatening, but could actually compound into something that could be dangerous. So we still can't discount that this could be a event that could um, develop into something that could put the patient in jeopardy. So if I just unpack, okay, petechiae, right? So the way I think about petechiae, if there is a infectious or toxic association, you have to start thinking about the infections. And our friend Yasmin would be our cheerleader and say like, oh yeah, start thinking about meningococcemia, start thinking about disseminated gonococcal infection, Rocky Mountain spotted fever, HSP could be another one, or you could get um, I guess, embolization from endocarditis into the leg, causing something like that. Can any one of these cause anemia? I guess the jaundice, if I preemptively associate the jaundice from the anemia, which one of these could cause it? I think namely endocarditis, if the valve is tight, can cause hemolysis, causing what's called something that's caused like a whirring blender syndrome, where the tight valve would just shear and cause a non-immune mediated a MAHA in this case. But if this is something that is this petechiae is happening in an afebrile patient that is not toxic, you then have to start exploring. And I think we did this. It's kind of like deja vu again, Mark. You have to start thinking about vascular problems, right? So the petechiae, is it something that is palpable? Could it be a vascular disease? could it be something that's of a viral etiology? If it's something that's non-palpable, in that case, it would be from thrombocytopenia. We don't even have the amount of the platelets yet, but you have to think about what could cause platelet destruction. So things like an immune process like ITP, could APLS cause this? There's no mention of heparin. If this patient had heparin, we calculate a 40 score and maybe decipher if the HIT syndrome is happening. And I think also you have to wonder about nutritional deficiencies impacting the vessel, like scurvy. So I don't think this patient is toxic where you have to explore the landscape of pulmonary fulminans, DIC, or TTP in this case. But again, we don't have the platelet count. But what would be red flags for petechial rash? I think fever would be. I just named toxic appearance, hypotension, and being critically ill would put your antennas up for a toxic cause of a petechial rash. The hemolysis may be secondary to this, but this rash could actually give us the clues as to what's going on. And then the meds. Vinny gave us a boatload of meds here. I would start going through them to see, could there be, how can you relate meds to an anemia, especially hemolysis causing jaundice? G6PD deficiency could be a cause here. So if this patient was started on Bactrim, which can be a notorious cause of G6PD manifestations, that would be something to think about. Hydralazine, we had a case of, on morning report, hydralazine induced lupus or drug-induced lupus. So that's something to think about. And I'm trying to think about the other ones, but I kind of said a lot there, but I'll hand the mic over to Mark.
Yeah, this is such a rich aliquot. I think for me is the time course of all these events is like, I think so important. And so I just wanted to ask a clarifying question. So the patient came in with anemia, got 3 blood transfusions, and then 2 days later developed jaundice. Is that correct?
So yeah, that's correct. The patient had 3 blood transfusions, and subsequently, with the course of days, he started developing the jaundice, and it was specifically 2 days after that the jaundice started.
I see. And then the petechia, same thing, like jaundice and petechiae developed about the same time. Like it wasn't present on admission, and then it was present.
No, it wasn't present on animation. The PTK came afterward, the blood transfusions, and concomitantly with the jaundice.
Gotcha. So helpful. Yeah, I'll just kind of just talk about just complications of blood transfusions, because for me, it's really tough for me to like not anchor on this being a complication on blood transfusions. I'm definitely going to keep the DDX broad and think of things related or not related, but hemolytic transfusion reactions are very, very common. And there's many different blood transfusion reactions. There's acute hemolytic transfusion reactions, which usually happen very shortly after, definitely within the first 24 hours. But this would fit more in the delayed hemolytic transfusion reactions, which happens anywhere from 1 day to a month after a blood transfusion. And then there's also this less common entity of post-transfusion purpura, where essentially there's like antiplatelet antibodies that develop as well. So that could be a nice, like almost like unifying diagnosis, right? The patient has a delayed hemolytic transfusion reaction and then a post-transfusion purpura. Another thing to consider is that it's exceedingly rare, and I've consented so many patients for blood transfusions, but I say it every single time. There's a very, very small risk of transmitting an infection with a blood transfusion, and these infections that can get transmitted are actually mainly tick-borne infections because they're not screened. So classically, Babesia is an infection that can be transmitted via blood transfusions. Lyme disease can. Even like variants of CGD can be transmitted. And a lot of these like tick-borne infections, right, can cause, especially Babesia, hemolytic anemia. They can cause thrombocytopenia, which can lead to petechiae. So I think that's interesting. Platelet transfusions, which this patient didn't get, but just for like a teaching point, are more likely to cause like reactions because of the different temperatures that they're stored at, and actually can cause like GNR sepsis. I think it's mainly related to the temperature that they're stored at. But this seems like this patient didn't get any um, platelets. So I would definitely test for these tick-borne infections, and I'm definitely very interested in the CBC to see the patient's platelet count. Um, and then was the knee swelling also was like de novo, like after the blood transfusion as well, like that wasn't present previous, and it's just like a monoarticular swelling essentially.
Yeah. So can you repeat it?
The knee swelling, that wasn't present on admission, but then was present after the blood
Yeah.
transfusion. Okay.
Yeah, that's it. Perfect.
Gotcha. Um, so like I think we've talked about monoarticular arthritis as well, and I definitely would want to do a really good joint exam to see if there's any other joints involved, especially because we're getting some a sign of like a systemic illness here, and Ravi mentioned like vasculitis, which can have can cause a oligo polyarticular arthritis. So, but if we're truly monoarticular arthritis, we're really looking at crystalline disease or infection, right? So I think if we can tap the knee, that sometimes depends on the platelet count and stuff. If this platelet count is like 5, then maybe the orthopedic surgeons, whoever taps knees, maybe won't be too happy about tapping a knee. But if we have a good size effusion, we're able to. I think it would be very important because actually a pretty rare manifestation of hemolysis, especially in a patient that's predisposed, is gout because you have all that cell turnover and that could lead to a little bit of hyperuricemia. So if this patient has hemolysis, maybe they're predisposed to gout. But I definitely want to tap it to rule out infection as well. And I'm very curious in the joint exam to see if this patient has like a micromotion tenderness, which would be more consistent with septic arthritis. But I'll just highlight the last thing that Ravi said. I do not like hydralazine. I really, really do not like it. I think it's a terrible medicine. And, sometimes you have to use it also, especially in like CKD patients, if there's no other options to control their blood pressure. But please, 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 like exhaust every other option almost in the world besides hydralazine, because it makes the pharmacokinetics makes your blood pressure go like this all day long, just up and down, up and down. It also can cause coronary steal syndrome. And patients with CKD, most of them have coronary artery disease. So it's a bad medication for that as well. And then all of the autoimmune phenomenon, drug-induced lupus, drug-induced ANCA vasculitis, which can happen really along any, usually it's with prolonged use, but it can be acutely as well. So yeah, I'm very curious to see if this patient's toxic, like Ravi was saying, and then very curious in that CBC and LFTs as well. And if this isn't related to the blood transfusion, and we can kind of, I think, widen our differential as well to like hemolysis related to CKD or just other causes of hemolysis. But yeah, very, very cool case.
Right. So for the third aliquot, I will review the physical exam and then I'll show you a picture. And so the patient appears in regular condition, is pale, jaundice, a 2+ jaundice, mildly dehydrated, and bilateral visual impairment, secondary to retinal detachment. The blood pressure is 140/90, heart rate up 87. Respiratory is pretty normal, and the SpO2 saturation is 96%. Abdomen reverse distended with diffuse petechiae and otherwise normal. Neurological pretty normal. So skin and extremities purpura on lower limbs, particularly from calves to feet, and bilateral asymmetric edema in the left lower extremity from the knee with limited range of motion. And calf has like no signs of DVT. And let me try to share my screen. I just sent out a request and yeah, so can you guys see? Let me, yeah, that's it. Okay, so I'll stop it. Oh, I'm sorry, I'll stop share. And Now continue with some lab results. The white blood cell count is 88, 8. Hemoglobin is 5, hematocrit is 16, MCV of 90, and RZW of 20. I'll just pass and copy in the chat also too, so you guys can see better. Yep. And continue the alkaline phosphatase of 300 with a GGT of 531, AST of 86, ALT of 49, and TSH of 20 with a free T4 of 0.87. The amylase is normal. Urea, I don't have the BUN, but you can consider that's very high, okay? It's 157. The creatinine is 10.3, sodium of 137, potassium of 5, magnesium of 3, ionized calcium is low as 1, and albumin is 2.9. So let me give you the platelets that we're just asking here. Yeah, give me a minute. So I'll continue meanwhile. The ESR is 123, CRP of 7, coagulation profile is normal, uric acid is 8. Now we have a urinalysis that shows 1 plus blood, a 33,000 leukocytes with a 24,000 red blood cells, ferritin of 510, TSAT of 17, haptoglobin of 308, that is high, and serologies and Hep B, Hep C, and HIV is negative. And the platelets is 261. So yeah, we also did an abdominal ultrasound that showed splenomegaly and hepatic steatosis, and we have a left lower limb ultrasound that is negative for deep venous thrombosis. That's all for this aliquot.
Wow, a lot of twists and turns. Um, maybe I could chat, Ravi, because you were chatting about the petechiae, but do you want to take the exam and maybe I'll take the labs? Because you were talking about like petechial rations.
Sure, sure. So when we talked about petechiae, right, we were first thinking about, okay, there's got to be a thrombocytopenia here. But usually petechiae might not always be due to the downturn in platelets. It could be due to platelet dysfunction. You were thinking about you wanted PTI and RPTT. If there's a coagulopathy and if the vessels are, somebody mentioned about your scurvy discussion, so loss of vascular integrity could also be an indicator of petechiae. But here, clearly the platelets were, let's see, it's not filled, but I think they were low, right?
The
The white,
petechiae, no, the
no, I
what?
mean
The
the
white blood
platelets.
cell. The platelets is normal, is
Oh,
206.
okay, sorry, it was missing from the chat though, but okay, 206. So actually normal. So in this case, then we have to shift our attention to, is this if it's not a thrombocytopenia, is there a loss of vascular integrity? Is this a impairment of the coagulation cascade? So I don't see amongst the labs PT, PTT, INR. And then one of the thoughts we had was hemolysis, but with the haptoglobin being normal, LDH being normal, the narrative is building towards a non-hemolytic anemia. So I think clearly at this point with the anemia, I don't think there's only a isolated anemia. There's no thrombocytopenia. There's no downturn in the white cell count. So the bone marrow is probably not the source of this. But I think at this point, we definitely have to look at nutritional causes. We also have to look at the factors. And then in this case, we may have to focus our attention back to the liver. There is inflammation. It is kind of odd. The SED rate's high and the CRP is lower in this case. So there is a pattern building where usually, like, I think lupus can give you something like this. But if Mark, actually, I'm kind of deviating, but going back to let me go back to the exam. So the purpura is on the lower extremities, calves to the feet, and petechiae, and there's also edema, and clearly the albumin is low in this case. You have to start thinking about with the edema, is there increase in hydrostatic pressure, decrease in oncotic pressure, but clearly here the oncotic pressure is an issue, and there is some edema. Is there hemorrhage into the dermis, epidermis causing edema? Probably not, but there is a clue in the thyroid. I'll let Mark tackle that to at least allow him some room to discuss. I don't want to take over and discuss everything. So a couple of interesting things here. Definitely the coags are not disclosed yet. And there's a lot going on more in other systems like the kidney and so on. But I'll turn it over to Mark. But I don't think I can make more progress than that with the petechiae. But the platelets are fine. So I think you have to look at something else, namely the vessels, maybe a multi-system disorder, including the vessels, or the liver and the coagulation cascade.
Awesome. Yeah. Wow. This is not what I was expecting. I thought this was going to be like haptoglobin was going to be less than 30, LDH was going to be through the roof. So this is really interesting. And I just want to clarify. So it sounds like the bilirubin was 12, mainly direct hyperbilirubinemia.
Yeah, that's right. I just forgot to say that out loud.
Gotcha. And we have a right upper quadrant ultrasound that shows no ductal dilation, but does show some steatosis and splenomegaly. Is that?
Yeah, that's right, Mark.
Ravi was talking about the anemia. I'll kind of just really also just focus here on the direct hyperbilirubinemia. And do you know what the direct component was? Was like 10, 8?
The anemia. What more specific do you want?
Or in the hyperbilirubinemia. Do you know how much of it was direct? Like the total was 12. Was it like 10 was direct?
The direct was 8 as high, and then during hospitalization, it was decreasing. But when he came to us, it was a total of 12, and with direct predominance of 8, with 8.
Gotcha. Okay. So I'll kind of go back to what I talked about before. So we have a direct hyperbilirubinemia. It seems like our coagulation profile is normal. Our patient, is not altered, so we're not, worried about acute liver failure here. Are we concerned for cholangitis as any component of the syndrome? It seems like probably not. We're afebrile. I know there was a fever. It seems like at the outside hospital, but we're afebrile. Our white count is normal. So it seems like that's less likely. Kind of like the algorithm, right upper quadrant ultrasound is good. It's not perfect. I've seen right upper quadrant ultrasound miss ductal dilation, miss things in the hepatobiliary system. Alternatively, I've seen CT abdomen pelvises miss things in the hepatobiliary system, and the right upper quadrant ultrasound is positive for something. I think Zavin had a great tweet on this, on just like the test characteristics of the CT abdomen pelvis versus the right upper quadrant ultrasound. The data is very mixed. So when I have a high suspicion for some sort of hepatobiliary pancreatic pathology with a direct hyperbilirubinemia, honestly, I usually start with the right upper quadrant ultrasound. If that's negative, I'll get a CT abdomen pelvis. It's that negative, then I go to an MRCP, because it's just, for me, there's just likely something, because it's such a direct component in the hepatobiliary tree that I think needs to be evaluated for. And Vinny, was the bilirubin at the outside hospital elevated on admission? Like
No, the
before the
bilirubin was not. No, it was normal before the blood transfusions.
That's so interesting. I mean, because most, I guess the question is that did this patient have a component of hemolysis, that caused jaundice, like after the blood transfusion? and then the patient has, multiple, diagnoses that are causing anemia and direct hyperbilirubinemia, because it's hard for me to disconnect that the patient got a blood transfusion, then developed symptoms. Like I feel like there has to be at least a component of a complication of a blood transfusion. But I think I definitely would get a CT abdomen pelvis, especially because I think you told me also that patient has abdominal distension as well on exam. And this goes back to the case I recently presented, very similar actually, besides the hyperbilirubinemia. Patient had isolated anemia, abdominal distension, and a patient with CKD, and they wind up having hemoperitoneum. Now, those patients are usually pretty unstable, but as in my case, my patient was actually relatively stable. And this patient, the thing that might be saving these patients with CKD is that usually if they're usually very volume up and very hypertensive. So who knows, maybe this patient has a baseline blood pressure of 180 over 120, and this is relative hypotension for this patient. And they're also on co-reg, hydralazine, and amlodipine, which is blocking a tachycardic response. So I'd just be very interesting in other like a lactate and other perfusion markers, but that's another reason why I would also get a CT abdomen pelvis to make sure that abdominal distension, really to see what is that abdominal distension. Sometimes a right upper quadrant ultrasound can tell you if it's ascites or something like that. But is it fluid? Is it hemoperitoneum? Is it ascites from CKD? Is it just constipation? That's why the patient has abdominal distension. Is it this splenomegaly that the patient has? So I think I definitely would get a CT abdomen pelvis. I'm really struggling to link the petechiae to the abdominal dissection and direct hyperbilirubinemia, but I just worry, is there a pancreatic cancer? Is there something just in the hepatobiliary tract that could be bleeding, leading to the isolated anemia? And then the last thing I'll say is too, in that case that I presented, the reticulocyte count surprisingly helped me a lot because I thought it was going to be hyperproliferative in my case because the patient had ESRD and usually doesn't have any EPO unless they're getting it supplemented. Do we have a reticulocyte count for here for this patient?
Yeah, I'll reveal in the next eloquent. Okay,
Okay, gotcha.
if you want, I can reveal now.
Reticular, you have 16.5, is that right?
Let me
In the
confirm.
chat, And the normal was 2%, but he's 16.5%.
Yeah, that's it. That's
Okay.
it. Perfect.
It was in the chat, Mark.
So 16.5% reticulocytes.
Yeah.
Okay, so very high. Honestly, you don't even at that point need to calculate a retic index. Like that is like severely elevated, which is interesting, which usually is bleeding or hemolysis. And as Ravi said, we don't have a lot going for hemolysis right now. So I'm definitely concerned that this patient could be bleeding in their abdomen from some cause. And I think a CT abdomen pelvis would be really helpful here. Yeah, I think I'll kind of end there. I'm curious what the next outcome is. This is a tough.
Mark, what's interesting, I just want to add before it's a lot to process here. But then what kind of you need to do, the two things that kind of I was thinking about when you were discussing, I stood back and I sort of observed the whole, I guess, case here and try and figure or think about what really could help us to make progress here. I mean, number one was with the exam, I didn't really pay attention, but the bilateral retinal detachment, is that what there was something with the eye. So bilateral visual impairment secondary to retinal detachment. It's kind of odd. Is that something, Vinny, is this
That's
something that's
chronic.
that's chronic? Okay.
Yeah,
So it's
yeah.
not anything to
He's
do with
blind.
this. Okay, got it. All right, second thing, this splenomegaly. And what was interesting when you touched upon this transfusion, okay, this patient's getting transfusion, but then again is still anemic. So you have to wonder about anemia, basic elements. You don't make blood, you break blood, or you lose blood. Here, the retic count's elevated. So when you're not making blood, you don't, your retic count doesn't respond, right? So that's an intrinsic bone marrow issue unless you have B12 deficiency and have intramedullary hemolysis. The other thing is if you're losing blood, where are we losing? I don't see anywhere, like spaces could be thighs, the retroperitoneum. We're seeing some signal in the skin, but that's not enough to explain the 5. Transfusion reaction. You did a great walkthrough of transfusion related to hemolytic anemias, which is usually Coombs positive, and it's a autoimmune phenomena. Here we don't have a Coombs yet. But again, we don't, the haptoglobin is normal, LDH is normal. So I think we can sort of scrap that unless there's a low intensity of hemolysis here. Peripheral smear may be helpful too. But this splenomegaly is interesting. Like, okay, when you go through, CPS has a great schema on splenomegaly. And then if you look through the cause of splenomegaly, what could relate to what we're seeing here? So you have to think about, infection. Me and Mark had talked about certain infections like tick-borne illness, viral infections can cause it, granulomatous infections. Here we also don't have a white cell count abnormalities, and some of the myeloproliferative disorders less likely. Malignancy, some people were chatting about maybe if there's malignancy. Epidemiologically, it could happen. Autoimmune phenomena, not sure. So could there be RBCs? Babesiosis was floated early as a cause, right? Commonly, it is seen in transfusion. And although babesiosis, yeah, this could be, I think you get splenomegaly, but you don't get hepatomegaly. With malaria, you get hepatomegaly as well. And then infiltrative disorders like amyloidosis. And we talked about vascular integrity. So amyloidosis can cause, I'm trying to remember the nerve, but it can cause loss of integrity of the wall and then bleeding into the skin too. So hematomas and so on. So it can cause, it'll come back to me, the term. But amyloidosis, is that something? I don't know. Are you getting a sense of portal hypertension here?
I
So
guess
far, no.
yeah, the
Yeah,
platelets being normal, I guess,
yeah,
unless there's something else driving up the platelet count.
yeah.
Yeah, maybe makes it a little less likely. Yeah.
And with splenomegaly, you do get thrombocytopenia, right? That's a straightforward cause, right?
Yeah.
So maybe the platelet count is much higher with splenomegaly, and we're not seeing the true platelet count here too. So a lot of confusing. It's very confusing at this point, but I think imaging to see exactly better imaging, which would be a CT scan in this case, to help us. Do we need a peripheral smear? We're not getting a sense of hemolysis. I doubt we'll find anything there. But yeah, let's go with that and see what happens.
I, I just want to mention just two more quick things. I feel if this patient was hemolyzing, I think this would be such a good case for Babesia, given the risk factor and the syndrome. I'll say I mean, the direct hyperbilirubinemia, I've seen this before where like, I think I presented a case, or actually my wonderful intern Luke did, to Ravi and Reza, of autoimmune hemolytic anemia. And sometimes especially when patients that have a liver disease, the ratio of direct and indirect in hemolysis it might be a little more direct than you might think, because it takes the liver a little time to process the bilirubin. So I would repeat the hemolysis markers again. Just like, so I feel like as I went through residency, and especially as a new attending, when things don't make sense, a lot of times I'll just repeat labs. So I definitely repeat the hemolysis labs again and definitely get a smear. And the last thing I'll say, because it's tough for me to remember this on the petechia ischemia because it doesn't really fit perfectly anywhere, is endocarditis, because endocarditis can also do whatever it wants. Because this patient likely has a line, or like a graft, or a fistula, or a tunnel dialysis catheter, something that increases their risk for a bloodstream infection. So I think blood cultures would be really helpful. And then the most common skin manifestation of endocarditis is not Janway lesions, it's not Oser's nodes, it's petechia and purpura. So I definitely would love, I know there was no murmur exam, but, and there's no fever. Fever is usually pretty sensitive, but I definitely would get blood cultures. And then would definitely have a low threshold to think about endocarditis. Sure.
Yeah, the other thing, because again, there's a lot of data here. The thyroid labs here. So the TSH is 20, which is markedly elevated. And then the T4 is 40.87. So both of them are up. So in this case, it's very unusual. I've never seen that kind of pattern. But what do you think about that? That TSH, it doesn't follow the normal trend. I mean, if TSH is up, 3T4 is down. It's due to primary hyperthyroidism. But if TSH is up, and usually with illness, you kind of may have subclinical hypothyroidism where 3T4 would be normal and TSH is up. But this pattern is very normal. What do you think about that?
I think someone just clarified in the chat that the free T4, is that normal at 0.87 actually, Vinny?
It-
Well, maybe an error.
It's
Yeah.
it's mild low.
Oh, it's low. Okay, so it's 0.87. Okay,
Uh,
somebody that mistyped 40.87.
Yeah. Yeah, I mean, I've learned to, I feel like over time, just like thyroid studies in the hospital are just like so unreliable. And I think really for me, the one of the only roles I think for ordering thyroid studies in the hospital, or if you're concerned for myxedema, coma, or thyroid toxicosis, kind of the extreme syndromes of like thyroid disorders, because it's just like they're so unreliable because of euthyroid sick syndrome, especially someone as sick as this. Even people argue that hyponatremia is really not a manifestation of just run-of-the-mill hypothyroidism. It's really just myxedema coma. So I know we order TSH in that setting too, but so maybe this patient has subclinical hypothyroidism or mild hypothyroidism. It's tough for me to connect that to everything else going on, the hemolysis, the petechiae. But yeah, it's always on the list because they always get ordered, but then it's like follow up thyroid function test as an outpatient. Usually
Yeah.
that's like always in my note.
Yeah, I was making a mountain out of a molehill. I was like 40.87
Yeah.
T4. What is that? But glad people corrected that, and I didn't have to waste any more cognitive energy. So let's move on. Yeah, it's still kind of nebulous, the picture, but let's see in the next aliquot what we can find.
All right. So for the next aliquot is the last one before the diagnosis, and about the CT scan, it was normal, and we are thinking about the in the same about in the same line as Mark about the thyroid thing, and so yeah, we haven't considered that and haven't put much that effort about thinking about the thyroid. And we have I need to confess that we have in particular issue with the blood smears in our service. So unfortunately, again, I don't have a blood smear. But let's continue. The CMV and EBV serologies on both IgG and IgM was non-reactive. ATLV1 and 2 was non-reactive. And then we proceeded with protein electrophoresis and immunoelectrophoresis that showed an increased IgG and IgA without monoclonal peak, well, which is normal. A complement C3 of 227, a C850 that is normal, a C4 of 33, that's normal also. P ANCA and C ANCA came back negative. Direct and indirect CUMs came back negative. ANA and rheumatoid factor and AMA were both negative. And we then proceeded with a cryoglobulin test that was conducted at room temperature at 29 Celsius degrees, right? So 29 at room temperature. And then came back also non-reactive, right? That's all for this aliquot. I'll put that in the chat.
At this point, I don't know if you want to start. So the CT was normal, but it did show the splenomegaly, right, Vinny?
Yeah, show the splenomegaly. That just was non-significant for other findings and lesions. And so we also had the hepatic steatosis, but otherwise normal.
Yeah, so it's interesting. The kidney also we did because it's just a maelstrom of so many lab abnormalities. I definitely my head is spinning. So now, if I break it down into its basic elements, I mean the kidney was severely abnormal, right? the BUN 157, creatinine 10.3. I think baseline was normal with the bilirubin. It's not of a hepatic etiology here. It's non-hemolytic. I mean, renal failure, hyperbilirubinemia, hemolytic anemia. You have to wonder about TTP, HUS, atypical HUS. DIC probably not as well. So we talked earlier about vascular integrity. So amyloid vasculopathy. Maybe that was the term I was thinking about. So that was something to think about here. So myeloma can result in that, can result in nephrotic syndrome. Do we have the urine analysis, we don't have protein listed here. Do we have, because the albumin was 2.2, was there protein listed?
I'll check here. Give me a
Okay.
minute.
Okay. Because certainly there's a lot to kind of comprehend with all these lab abnormalities. But I'm very interested to see what's going on with the kidney. Is this kidney the center of gravity and everything else having or coming after that secondarily? And then cryoglobulin tests are room temperature non-reactive. So that's an interesting hypothesis. I mean, when you have say glomerulonephritis, you have purpura, and then you have also joint involvement. That does actually float an interesting hypothesis there. And there was a very nice NAGM review article going through cryoglobulinemia and describing the different types and the organ damage that tends to happen via a mechanism of vascular sludging or immune mediated mechanisms. That's something I definitely would look into. Complement being normal, so essentially ruling out the complement associated renal syndromes, so like post-streptococcal GN, lupus would also be ruled out in this case. But while he looks for the protein, what do you think at this point?
This is a tough case. And I just want to clarify, the patient on dialysis, right?
Yeah,
Oh,
that's correct.
I forgot that. Okay,
Okay. I just
I
wanted to make
forgot
sure.
that.
I was like, oh
Okay.
no, we didn't forget a creatinine of 10, right?
Yeah. Oh, yeah. I missed. Again, there's a lot to. This is where actually a problem representation would be helpful.
Yeah.
And we
And
have one up there.
yeah, and exactly what Elena was saying in the chat is like I'm still like in the problem defining stage. Like I know we have to figure out why this patient has petechiae and purpura. We have to figure out why this patient has direct hyperbilirubinemia, and we have to figure out why this patient has a severe isolated like hyperproliferative anemia. Like those are like the big things, and like we crossed a lot of things off the list. Cryo is definitely interesting. I don't know if the hint at like collected at room temperature as opposed to collecting it cold on ice. But I think I remember rheumatoid factor being negative, which is kind of quoted as like the poor man's like cryo. The sensitivity, I'm sure, is not 100%. I'm not sure what the sensitivity of that is, but complements are usually low in cryo as well. I kind of remember like cryo is 4 letters, so C4 is usually low. And I just want to clarify too, the SPEP did not show any M spike at all. No.
That's correct. No
Okay.
monoclonal
So
spike.
yeah, Mark, what's interesting is, yeah, I presented a case of a patient that was on dialysis, but then the patient was never worked up at a center for the dialysis, like the kidney failure. It was presumed to be due to case of sepsis and kidney failure. And then the patient developed spontaneous bleeding and had amyloid angiopathy. So we can still float the idea that yes, the patient's on dialysis, but did they ever work up why the patient had kidney failure? So you could still bracket that hypothesis as possible, but at this point, yeah, we still have to explore the top most likely causes of such a presentation.
100%. Yeah, I had the same situation that a patient wound up having lupus that got their kidney disease was attributed to just hypertensive nephrosclerosis, and they wind up presenting to me with like symptomatic serositis, pericardial effusion, and it was lupus all along. So totally, that's such an important point. And I'm just trying to think of how to make progress with those key signature features that I mentioned. I still am curious about an MRCP. It's tough, again, for me to link it to everything else, but the hyperbilirubinemia is so severe. It's causing jaundice, is 12, is direct, and we have a negative CT abdomen pelvis and right upper quadrant ultrasound. Again, I think Vinny mentioned that it just like decreased during the hospitalization. I'm wondering if it totally went away and this was just a transient process. Is that, Vinny, was the patient jaundiced the whole admission and before maybe treatment of certain disease that is really hard to figure out?
No, the patient was just started the jaundice as I said right after the blood transfusions, and then during hospitalization it was decreasing. I'll just check and at what level is right now, and I will answer in a few seconds.
Gotcha. Okay, because yeah, I mean, if it still had significant, direct hyperbilirubinemia, I think that's kind of just on the algorithm of like a cholestatic liver injury. It's just, when you got the AMA that was negative, you got the right upper quadrant, you got the CT, you think about infiltrative diseases like amyloid, like we talked about, the MRCP could be helpful. And then the petechia, right? Like what haven't we evaluated with petechia? We have the platelets, we have the coags. We talked about amyloid. We have some of diseases like small vessel vasculitis labs, that being like ANCA, and we talked about cryo, and so it's yeah. I mean I'm curious in a vitamin C level. I'm not sure how that would, now that I say that, vitamin C can cause hemolysis. Well, it could cause hemolysis, so I guess that the hemolysis work, but it can also cause anemia in general. It could cause leukopenia. Usually doesn't cause thrombocytopenia, but it can cause anemia. So I think that's one thing that we could, investigate further. I can't really link that to the splenomegaly, and again to the hyperbilirubinemia. And then was the splenomegaly present in the past, or is this all new as well?
Yeah, so we've done like a previous exam in for like months before, so I cannot assure that with 100%, but I think that it was a chronic issue.
Gotcha. Yeah, I'm just like maybe MRCP, a vitamin C level. Yeah, this is tough. And again, vitamin C wouldn't cause an inflammatory syndrome, so that's doesn't really fit perfectly there. So yeah, I guess if I had put is this the last aliquot? Uh, yeah, some sort of, so we have an inflammatory syndrome that's causing petechiae, direct hyperbilirubinemia, and isolated anemia. I think what are we missing with our autoimmune? Or I talked about endocarditis, but our blood cultures and echo, I think we definitely need. But what are we missing in our autoimmune? We got the ANCA, ANA. What are we missing anything in terms of our autoimmune, at least for this syndrome?
I think,
Hydralazine. I guess the
did we get a COVID test on this patient?
No,
Just
no COVID and no
okay, okay.
influenza, right?
I'm just wondering about something systemic that could cause multiple system sort of atrophy.
I think the hydralazine
Um,
lab, the drug-induced lupus labs, I think I'm blanking right now what the name of the drug-induced lupus, a histone, antihistone
Histone, right, right. So
thing could be helpful.
remember this CRP-SR interesting sort of interplay that you can get. So that that was, yeah, there was a case where we did figure out, because the CRP was normal and the ESR was really elevated, and usually both go hand in hand unless there is liver dysfunction, right? So CRP is made in the liver, IL-6 upregulates. So inflammation, IL-6 upregulates, goes to the liver, upregulates CRP in this case. And CRP is like a direct indicator of IL-6. And again, we keep going back to this, to the liver. Is there an issue with the liver? On the image, there's no hepatomegaly, there's no cirrhosis, there's no stigmata of cirrhosis. The GGT is elevated. That is also interesting. What, again, primarily liver disease causes obstructive cholestasis causes GGT elevation. Alcohol causes GGT elevation. I think hyperthyroidism causes GGT elevation. Certain drugs could do it too. But yeah, I'm still it's it is very confusing. But of an autoimmune condition, I mean, like APLS, catastrophic APLS could cause something like this. But again, the coags are normal, and it doesn't make sense in this case. But I guess we can learn from the final aliquot. Sometimes, yeah, we
And
come to VMR without a real answer for these things.
yeah, and then the last just like very low hanging fruit is that like we definitely should get hepatitis serologies as well, and especially because we're talking about cryoglobulinemia, Hep C being a trigger for cryo and other medium to small vessel vasculitis. So that's just really anyone with liver abnormalities.
Oh, Mark, interesting. Okay, you just mentioned that. You know what triggered in my mind? So look at the protein electrophoresis. What increased?
The are you? Oh, so this patient has a polyclonal, but not
Yeah.
yeah, interesting. I like it didn't register in my head because I
Yeah.
usually don't read it like that, like this. So the patient has a polyclonal gammopathy. Yeah,
Yes.
yeah, yeah.
Yes. You just mentioned that, and that's the pivot point there. So we have to think about a polyclonal disorder in this case. What
Yeah.
comes to mind?
Yeah, I mean, it's chronic infection, chronic autoimmune disease, and malignancy, but the big, like, notorious causes are hepatitis, HIV, endocarditis, and
Yeah,
so those are, I think, hepatitis serologies and HIV would
right.
be.
And HIV is important in this case.
Yeah, yeah.
Okay. Okay.
Okay,
What?
so yeah, so about the C4, it was not in the whiteboard, but it was normal also. All right. And so now that I've revealed the final diagnosis, I need to confess that I was just puzzled as you guys, and I cannot explain like something, some lab tests, and what is all the pathophysiology behind the disease and all that spectrum that the patient presented. And but now let's continue. So I, I, I'm trying to present as the reality, and that's not a threat. And the thing is that the cryoglobulin test was performed in a wrong way because it is not performed at a room temperature at 24 degrees. And then we repeated the test, and this time the blood was collected in a tube kept at body temperature at 37 degrees to prevent any premature precipitation. And then the sample was then refrigerated to allow cryoglobulin precipitation if present, and the result came back positive for the presence of cryoglobulins. And then afterwards, we sent in skin biopsy result that showed leukocytoclastic vasculitis that was consistent with cryoglobulinemia. So just to summarize some few points that the patient was initially admitted at our service with the suspicions of delayed transfusion reaction, and however all the serologies and antibodies came back negative, which led us to consider cryoglobulinemia as in the differential diagnosis. And one was an aspect though was the normal C4 level that and this typically arcs against cryoglobulinemia. But well, I don't know how to explain that the C4 was normal and the patient was revealed to have cryoglobulinemia. So yeah, that's all from my part.
Oh my gosh, my head hurts. That was a lot to chew on. I think we did a whole textbook of probably hepatobiliary, renal, skin, coagulation, thrombocytopenia, anemia, and so on, run through. Um, but I'm kind of glad we touched on it. And like you mentioned, Mark, yeah, a lab can always be done in not the correct manner. So do question the labs here. But it was very interesting that Cryoglobulinemia, we talk about this Meltzer's triad due to a mixed cryoglobulinemia. And Eleanor put the link to the NHM review article from a couple of weeks ago on cryoglobulinemia. So with Meltzer's triad, you get weakness, palpable purpura, and also this arthralgia, which could be a manifestation in this patient. But yeah, I have the same question, like what is the cause here? I mean, it can cause a GN, but this patient's end-stage renal on hemodialysis. But cause usually will be, like Mark had mentioned, doing the HBV, HCV, HIV test in this case. And occasionally you can get lupus and rheumatoid causing this as well. But yeah, I'm kind of interested to see. But I think that polyclonal abnormality on the SPEP, yeah, we kind of glanced over that, but that was a big clue to this. Mark, any final words for this case?
Yeah, I think just and in my very short career, I've just realized like if the syndrome fits, but the labs don't fit, really just try and get the confirmatory test or just repeat the labs. I think that a couple times in my very short career, like that has helped out. I didn't feel like I didn't do that in the beginning, and now just as I gain more experience, like when the syndrome fits and it fits here. The two things that are just I feel like are just loose ends for me is that what was the cause of the liver, like the direct hyperbilirubinemia, and then the severe hypoproliferative anemia? Those are the two things that are not clear to me.
Yeah, so I don't know how to answer that appropriately, Mark, but we don't know if the transfusion played a significant role on the precipitation of a triggering factor, and how the labs. I questioned I asked the attendant, and wow, that doesn't fit, and how I'll say that, and yeah, that it is what it is. I don't know.
Yeah, I
I'm
mean,
sorry for that. That's very frustrating. I understand totally.
no, it's real. I mean, it's real life, right? Like almost no lab is like 100% sensitive, right? Maybe this is hemolysis lab's negative cause of hemolysis, right? The AST is 2 to 1 with the ALT. Maybe that was a hint that there is some hemolysis or delayed resolution, of hemolysis, right? Maybe the patient had a transfusion reaction, and then when they presented to you guys, it started to get better, and then that haptoglobin and LDH are normal. Like
So
it's hard to put so much stock in like two labs, like.
yeah, I think that if you think about the basics with this patient, they already have pre-existing anemia, right? They have anemia of CKD. Patient is highly inflamed, anemia of inflammation. Then there's the icing on the cake, which is I don't know what, but there's, I would have imagined a hemolytic picture, a MAHA, non-immune mediated, due to the sludging in the vessels, right? When you have cryoglobulinemia, you have deposition, and that causes necrosis of organs and so on. So decrease in blood flow. So the blood pulsating through all of that complex could be sheared and it will cause a hemolytic anemia, but we don't see this signal here. So yeah, I'm a bit perplexed, but may have to read more about this.
Yes. So just want to thank you and all the comprehension and all the things that doesn't fit appropriately. But I try to be as have as much fidelity to the reality as it came to us. So thank you, guys.
And we'll have Patricia take us home with the teaching points.
Hi. What a wonderful discussion. Vinny, your cases are always amazing. Thank you so much. So today we learn about the approach to jaundice. We were like, when you have a patient with jaundice, we need to think pain or no pain, fever versus no fever. So it's important for us to rule out acute liver failure, infection disease like cholangitis, hepatobiliary diseases, which are usually associated with abdominal pain like stone or biliary strictures. We also need to rule out hemolytic anemia or inherited hyperbilirubinemia state. So Mark told us that the imagery for hepatobiliary and pancreatic system is usually in this order: ultrasound, CT abdomen, or MRCP. In this case, our patient had splenomegaly. Usually the causes of splenomegaly are infection, tick-borne disease, malignancy, autoimmune disorder, infectious disease like amyloidosis, or portal hypertension. We had a great discussion about petechiae, and we divided in two branches: petechiae, infectious or toxic association. We need to think about meningococcemia, disseminated gonococcal infection, HSV, or endocarditis. Also, bloodstream infection. And if the petechiae is not associated with fever, we need to see if it's palpable, and if it's palpable, we need to think about vascular problem like ANCA-related disease or cryoglobulinemia, which is usually associated with weakness, palpable purpura, and arthralgia. And if the petechiae is not palpable, we need to think about thrombocytopenia, like platelet destruction, TTP, the use of heparin. We also need to think about nutrition deficiency. In the best example is scurvy, where we have a loss of vascular integrity. Also, some medication can also cause petechiae, like hydralazine or GCPD medication. We talk about blood transfusion reaction, which have usually a positive cum test, and those reactions can be acute hemolytic, which usually happen in few hours, delay hemolytic, post-transfusion, purpura, and tick-borne infection like Babesia, Lyme disease, CGD, which can also lead to thrombocytopenia. In this case, we have polyclonal gammopathy, which are usually caused by hepatitis B, C, HIV infection, endocarditis, or lupus. We also had a GGT elevation, which is usually seen in case of liver diseases or alcohol. And the takeaway was that if we have a patient, the clinic fits and the lab do not be afraid to repeat the lab. So thank you for having me. Thank you for this session.
Thank you so much. See you, everyone.
Thank you. Take care. Bye.